Welcome to the Vol Performance Online Workshop Series. Thanks for joining us today. Really excited to have two fantastic practitioners with us in Alex Calder and Nathan Hironymous from the Houston Dynamo. And today we've got a fantastic presentation from each of these practitioners. For those of you who aren't aware, Alex is currently the Head of Sports Science with the Houston Dynamo in the MLS and is an accredited Level 3 elite coach with the ASCA. Previous to working at Houston Dynamo, he worked with the Orlando City Soccer Club in the MLS and University of Louisville and Purdue University. So bringing a great insight into our discussion today. Nathan has been part of the Houston Dynamo organisation for 8 seasons, so will bring a really great view and an idea around how they've progressed their physical therapy and performance program over the last 8 years. He's got 15 years of experience treating athletes, both from an amateur to professional level, and has worked with many professional athletes across multiple organisations and multiple sports. So fantastic insight from both of these gentlemen, and looking forward to the presentation. Thanks for joining us today, guys. I know it's morning in Australia and evening there in America, but really looking forward to the discussion today.
All right, yeah, so thanks for that, Selwyn. What we'll chat about today is a BFR application in rehab for elite athletes. What we'll talk about is just general overview of the return to play process within our departments, and then how we kind of plug and play to BFR in regards to our cohort, which is pro soccer players. So just prior to that, just a quick chat about the understanding of BFR and the protocols. I think it's important just to talk about the why and why we would do it in our environment, because if there's not an understanding of the why, then we're just kind of plugging and playing for without intent. So there's obviously a myriad of adaptations you can get from BFR, but I've just listed some of them, and I'll just do a brief overview, and then Nathan will go into much greater detail of what we try and obtain from certain individuals during the return to play process. So there's some of them, and there's plenty of lit reviews out now. Even one recent one out of Germany from Centner came out just identifying these and a few more, but these would what we would try and look at within our cohort with pro soccer players. So which is post-surgery, which is reduced atrophy, strength hypertrophy, and then some cardiovascular adaptations, which is obviously incredibly important for us. So just prior to that, I'll just talk about the return to play continuum that we have. This took quite a while to get to where we are now, and I'm pretty proud of where it is. I would say we're pretty effective in minimising time lost due to injury, and that's with our whole department, and we have some great practitioners and all our heads come together. But I really like this visual because the arrows overlay, which for me shows that there's never really a handoff. There's always involvement from every department. There just seems to be more transition along the way. So with us, being in America, we have athletic trainers. So when we do unfortunately suffer an injury, the ATs will work in conjunction with our medical staff and doctors to screen an individual, mitigate and assess the pain, interpret the epidemiology, which is the most important piece, because then that'll kind of dictate the estimated time for them returning to play. Then Nathan will jump on, our head physio, Nate, will jump on and start to initiate some exercise within the pain threshold that we use. We'll start to cross-reference some of the pre-season screening stuff that Nathan and I will both screen from both of our departments. And then Nathan will interpret pain and start recording this, and we'll try and be as aggressive as possible. And then myself and the other strength coaches with us will start to prescribe some of the bigger strength exercises from a neural and structural adaptation standpoint. We monitor within our technology that we use, start to apply some soccer-related worst-case scenario situations to drive some high-end adaptations as far as cardiovascular and even the strength stuff too. And then just basic increments as far as load management goes, which seems all pretty standard. And then we'll start to return them to team, modified training and modified game time. And this is obviously important too, because I want to outline this because as far as BFR application, it doesn't necessarily go into one of these parts or segments of the continuum. It can be plugged throughout. So it's important to why I address the why at the beginning, because there's certain times throughout the timeline that will apply some of those protocols. So this is as basic as it gets. Obviously, there's a lot more subcategories to assessing an injury, but if I were to just break it into kind of three categories, especially when looking at BFR, that top line, that top row would be how we would look at kind of a long-term injury, as basic as it seems. Post-surgery, the rebuilding, restructural, re-strengthening phase, and then the returning to play, returning to training situation. Middle one would be kind of mid to short term, where we're spending the first acute phase minimising the time lost, mitigating pain straight away, and then getting them back to training and their team lifts and team strength sessions. And then the last one, which I think is incredibly important, is just return to play or return to practice or whatever it's called. But for me, this is the group of individuals that we've assessed as being at a medium to high risk, but they're not necessarily losing time, training time or game time. So this is important, especially right now where we're in very short turnarounds, 3 to 4 day turnaround between games, where maybe we can't do the ideal strength training that we would have in a 7 day turnaround. But we have some screened individuals that need some strength adaptations, and these are perfect timing situations for piecing in some of our BFR protocols, which again, Nathan will go in a bit more detail and maybe elaborate on some certain individuals that we have currently. So I'll just talk about very briefly how our exercise selection works. So this is actually one of our players that suffered a minor grade 1 rec fem injury, and actually fell into that last category where he didn't miss any time from training. He may have pulled himself out of one drill where he did get assessed by the medical team, and we deemed him kind of fit to train the next day. But we do come up with a exercise selection and in terms of a regression progression kind of wave, I suppose you would call it. So initial screening is the first stuff that the ATs and Nathan will do, early stage into stage 1, 2, and 3. And the stage 3 is more so what the team lifts would look like, or some of the bigger movement, compound movements, where we'll try and drive some neural adaptations from a strength standpoint. But how to get there is this kind of continuum we use. And obviously we use this pain threshold that's been brought to light with Jack Hickey's recent research. But the reason I point this one out and this slide out in particular is because Nathan and I are in frequent communication about what exercises the player can do on that day and that week, and start to plan it out so we can have the progression and skeleton completely laid out for the whole anticipated time. And then the next step would be to choose which exercises we can apply a blood flow restriction to and yield some accelerated adaptations, and take into account our calendar and when we anticipate that player being back for games. So that's kind of how it looks, just from a global and whole standpoint. And then, Nate will dive in now into a bit more of the intricacies of it and certain situations. So I'll hand this over to Nate.
So I just wanted to just talk a little bit about kind of the background for me getting into BFR, or the blood flow restricted training. In November 2014, I saw an ESPN report that talked about tourniquet training, speeding recovery in wounded warriors as they came home and did therapy in San Antonio with a therapist there who was using this tourniquet training. So I started to kind of do some research and look up things and read a little bit about it. And I took it to a couple of people within my organization, and, they weren't super excited about it, not quite as excited as I was about it. But then in February 2015, the Houston Texans, the team there in Houston, the American football team, did a piece also in ESPN that talked about them using BFR training with one of their first round draft picks who had a pretty significant knee cartilage deficit that had to be repaired. And so they started to use this BFR, and they were seeing really, really good success with it. And so obviously once that came out, the Houston Texans were using that, then you started to see a couple of the clinics there in town start to use it. One of those was ours. And so we got our first unit in 2016 and started to use it in the clinic. So I've been doing this for about 4 years now with the BFR, and I really, really like it. And I think it's a valuable tool for us that are working with athletes and trying to get them back on the field as quickly as possible. Now, as we look at how and when to use BFR, we're going to break this down kind of in 3 different parts. The first part is going to be a passive training. The second part is going to be a resisted training. And then the third part is going to be an aerobic training. So part 1, our passive training. So this is what we call cell swell. Basically, what we're trying to do is we're trying to just swell up all the cells to help to accumulate metabolic stimulus within the muscle, particularly growth hormone and insulin-like growth hormone factor 1. And those things inside the muscle are going to do what they do. They're going to make you build muscle. And so in this passive part, this is really going to be for people who are just coming off of surgery, or they're in a long-term immobilization, whether they had like a foot surgery or knee surgery where they're just going to be immobilized for quite a while and not be able to do a lot of activity. And so what we've seen with this, or what the research has seen with this, is that they're going to have increased muscle mass and strength with the use of this swell cell. They're also going to have local skeletal muscle oxidation capacity and cardiovascular improvements. And so that's just putting this device on, and I'll show you the protocol that we use. So we will start this protocol the day 1 right after surgery. So when they have surgery, we'll send them home with a unit, and the following day they will start this at home. They're going to do this 1 or 2 times a day during that whole time that they're immobilized or they're at bed rest. They're going to do 5-minute intervals. They're going to do 3 to 5 set of these 5-minute intervals where they're going to have 5-minute breaks in between the 5 minutes of compression. And really all you're doing is you're putting the cuff on, and you're putting it at 70 to 100% of their arterial pressure, where they lose pressure within the artery. So you're basically cutting off the majority of blood flow. And so you're going to do this 5-minute intervals, and that's it. They're going to put it on. It's going to swell the leg. It's going to pool the venous return, and then it's going to release, and all that venous return is going to get released. And then they go through another 5-minute period which swells, and then it releases. And so it's a passive activity. They aren't doing anything except just sitting there with this unit on. And again, we can see improvements just by them doing that, and we can decrease the amount of atrophy that they have post-surgery just by doing that. Now, the second part is a resisted training part. And looking at the research, there are several benefits of this resisted training. One, increased hypertrophy, increased strength, increased muscle volume and cross-sectional area, increased rate of force development and explosive strength capacity, decreased disuse atrophy. There's also this really interesting article that shows that there's also a proximal, distal, and contralateral benefits to do in BFR. So let's say we have somebody who had a hip surgery and we want to strengthen the glutes. We can put this unit on and we could do quad sets, or we could do a hamstring curl. And at the same time, they are going to get glute benefits or low back benefits or hip flexor benefits, because the benefit is systemic. And so they're going to get benefits throughout the whole body, including the contralateral side. So let's say we're doing the swell cell on the leg that's injured, but because of the surgery, we can't do anything else. Well, we could put the unit on the contralateral side and have them do quad sets or hamstring curls, or, you know, if it's an ankle injury, we could have them do dorsiflexion and plantar flexion with resistance, and they would actually get benefits on the contralateral side. And so this is highly, highly effective when we have these patients that are in bed and they can't do a whole lot, or just out of surgery and they can't do a whole lot. And then finally, it's been found to be safe. There are a couple of things you have to look out for, but for the most part, there's no greater risk than normal exercise for using this, the BFR. Now, our protocol with this is our standard resistant protocol. This is what we would use for everybody. If we're looking at a post-surgical person, we might start this protocol about week 2 after the surgery. The first 2 weeks, they just do that swell, the cell swell, and then the second week, we'd actually start this. Again, we're trying to do this 2 or 3 times a week, or 2 or 3 times per day for that first 1 to 3 weeks. So we can actually do this a little bit more often initially, and then as we get into more functional activities, we decrease that. The load is going to be 20 to 40% of their 1 rep max. Now that can be hard to interpret for some of the muscles, and so we want to just use a load that actually allows them to get the reps that we want. And that's really the most important thing. The literature shows that the reps is the most important. So if you have a hard time, you know, trying to decide what's their 1 rep max on a certain activity, just make sure you're getting the repetitions and that they're doing those repetitions correctly. And that will give you a good idea about what that load needs to be. The restriction time is going to be about 5 to 10 minutes. We can do several different exercises. In between those exercises, there has to be that reperforation between each exercise. So we turn the unit off. It's going to give them a minute break or so in between the sets. And so that way we're just doing these 5-minute increments, and we can do 3 or 4 exercises with this reperfusion in between each exercise. This will work small and large muscle groups. So we can do, you know, small things like the rotator cuff muscles, or we can do big muscles like the quad or the glutes. We typically are going to have those 2 to 4 reps, or 2 to 4 sets, with the repetitions being the 30, 15, 15, 15. And really that's what the research says is the most efficient in building the strength and building the hypertrophy and doing all the things that the BFR does. If you have difficulty getting them to do those 30, 15, 15, 15, you can do sets to failure. So the 30 is the most part to really get the cells swollen the way we want to and build up that lactate within the muscle. And then after that, if they can't get the 15, you can go 10, 10, 10, or you can go 12, 12, 12. But you really want to try to get them to failure. If they're not getting those numbers, then maybe the load's a little bit too much, and I would look at adjusting the load. Again, the pressure here, we want about 40 to 80% of the loss of pressure. So I typically use the higher end. I typically am going to use the 80% loss of pressure. But sometimes I'll notice like their pressure that day might have been a little higher than it normally is. So I might bump it down a little bit just so that it's not too tough on them, because the cuff can get a little bit restrictive, especially if they're doing multiple exercises at the same time. So it's okay to kick that pressure down just a tad bit if they're struggling, if they're having a hard time. Again, you're going to get rests of 30 seconds in between each one of those sets, 30 seconds at least. The cuff is still on typically, so that you're getting some of that hyperperfusion of the and swelling of the limb that you're working. Execution is important. You really want them to go nice and slow with this, because you aren't using a lot of weight. If they're going really fast, then it's not gonna have the same effect of if they're going nice and slow. So I typically tell them you're gonna want a 1 second concentric and a 2 second eccentric, just so we're pushing nice and slow through those exercises. Now, looking at our exercise progression, this is our typical thing that we would do with either a recently injured athlete or an athlete that just had surgery. Obviously, depending on what they had surgical wise or what they had injury wise, those weeks will change. But just looking at those for a surgical patient, the quad sets, we start about again at that week 2. So we'll put it on and just have them do, the 30, 15, 15, 15 of the quad sets. The following week, quad sets, hip abduction, hip extension, and then some calf raises and TKEs. And again, we're just looking at getting all of those muscles. Obviously, for your knee, if you have an ACL or MCL or any of those ligamentous injuries, hips are critical to getting strong. And so hip abduction and extension is going to be important. And to me, the seated calf raises are also important, because that's a very functional activity, and we lose that very quickly. And our athletes that are sprinters or runners or anything like that need that strength in the calf. And so getting that calf working again is going to be something important. Week 4, we're going to add like a bilateral leg press. Again, I like to do the leg press just because it lets me unweight. Sometimes if I jump straight to body weight squats with the BFR, it's just too much weight for them. So I can start off with a bilateral leg press at 80 pounds or 100 pounds, and then slowly start to increase that. Week 5 is pretty much the same thing, except we'll add a hamstring curl just to get a little bit more of the hamstring in there. Week 6, we'll go to a single leg press. Week 7 and 8, we'll do body weight squats, a single leg press, and now a single leg hamstring curl, like on a machine or something like that, the hamstring curl machine. Week 9 and 10, we'll add a lunge. And then week 11 and 12, we'll add a step up. So you can see the progression starts off by just activation of the muscle to a little bit of activation with movement, to now some bilateral activities, and then some weight-bearing activities, double leg and then single leg. And that's just kind of the progression that I use within my exercise program. Going on to part 3 now. Part 3 is your aerobic activity. With the aerobic training, we can actually continue to see increased muscle strength and increased muscle hypertrophy. Then we also see improved functional abilities with daily tasks, and then this health and well-being. So I really like this. Obviously, we have our athletes need to walk and they need to do those things. And so if we can get them functional quicker, then that's just a benefit for them. And then finally, we can see increased aerobic capacity in young, old, and even the trained individuals. So that's really essential for us in the sport that we work in, is making sure that these guys are keeping their aerobic capacity and not losing that over time. And so with this program or protocol, we could either use a bike or we can use a treadmill. And again, we're doing this 2 to 3 times a week for 3 weeks and above, and 1 to 2 times per day for those first 1 to 3 weeks. Our load is going to be about 50% of their VO2 max. And so we're going to set that up to where, they're about 50% of that VO2 max. So it's not really a really hard program. We can do that for about 5 to 20 minutes per exercise. We can put them on the bike and have them ride for 15 minutes, and then put them on a treadmill and have them walk for 15 minutes, so that we're getting, a little bit more of those activities. Again, we're going to see benefits in the small and the large muscle groups. We're looking at pressure, about 40 to 80% of their loss in pressure. I typically do about 50% of that loss of pressure, just because it can get a little bit uncomfortable while you're sitting on a bike with this cuff on and then spin on the bike. So I typically lower that a little bit, but research says that anything between 40 and 80% is going to give you some benefits. Again, we can do this continuous or intervals where, in between we give them a little rest and we'll take it off and then we'll put it back on, and we'll just have them do that. And then again, we can do this either on a bike or on a treadmill. During this whole time, as we're getting these athletes back, I think it's important that we're continuously testing them to make sure that they're getting the benefits that we would like to see. So I'm testing girth measurements frequently. With those long-term people that have surgery, I'm looking at some of their functional activities, like the step down test, a wide balance test, a 1 rep max on the leg press, single leg, double leg, and then a single leg hamstring curl. And so I'm looking at those things to see where they're at testing wise. Then at 8 weeks, I'm going to go even more functional. Look at their pistol squat. Again, the step down, the 1 rep max, the wide balance, all of those things are important for us to look at frequently. And then around week 20, we're looking at some standardized test screenings, things that we would do with the team, whether it be like our preseason screening, or even like, giving them a couple of tries on the NOR and looking at their numbers there, or on the groin bars, so that we're looking at those standardized tests to make sure that they're headed in the direction that we want them to be headed. So going back to that continuum we talked about earlier, that Alex talked about, the long-term, midterm, and short-term. This is kind of how I would plug those in, and who would benefit from the BFR. And those long-term injuries, we're looking at, obviously, our post-surgical patients. Those are the ones that we're going to use throughout the continuum for the duration of their injury. For ACL, that could be four months. For other injuries, it could be a little bit longer. But this is highly beneficial in those patients. And so using those things for long-term is going to help them. The other thing is, you could have an athlete that has some type of degenerative disease or chondral defects, and maybe they just can't lift heavy enough to get the benefit that they need. The BFR would be a great way to help those athletes maintain their strength without stressing the joints. And so that's something that we would use with those types of patients, and have found great success with a couple of our guys who have chondral defects that we know of, and we can build them. Sometimes it takes 6 months, sometimes it takes a year of us working with that, and sometimes they continue on, but sometimes they're able to jump back into kind of the normal lifts. The next group is that mid to short-term injury group. These would be our muscle weakness or imbalance groups. Somebody who when we tested them preseason just has an imbalance, whether one side is weaker than the other, or the quads are weaker than the hamstrings, or hamstring weaker than the quads. We can use the BFR to target those areas and target those weaknesses over a short term, so that then they can get back to the normal team lifts and normal team activities. Acute injuries is another group that we would use this for, whether it be a hamstring injury or an adductor injury or a quad injury, such as what we saw earlier. The BFR is highly effective and highly useful in helping these guys shorten that time in which they can get back to some of those normal lifts. And so doing that with an acute hamstring or an acute quad injury is going to be super important. And then also our chronic injuries, like our tendinopathies, those guys that, that maybe have to sit out a couple of days because the tendinitis or the tendinopathy has gotten bad enough to where it's bothering them during practice. We can blast them with the BFR exercises and kind of help them to one, get the benefit of the cell swell, and also get the benefit of the strength in the area. And so I like to use this a lot for these guys with tendinopathies because it helps us to build some strength and to kind of push through some of that without really stressing the tendon more. And let's stress the tendon in the appropriate ways, by using our eccentrics or using our isometrics and things like that. And then finally, our healthy athletes, the people that remain available, but maybe we just need to do a little bit extra things with them. We're in a really tough part of the season right now, and it's hard to build strength because we have, games. We have 4 games in 11 days. It's hard to find time to do strength, but we can do some strength with the BFR because it's not putting a huge load, and so we're not causing the same DOMs or effects that we would have with really heavy loads with the BFR, but we can still get the benefit of the strength. This is also a great thing that we can use for recovery days. Get the guys in, either do an aerobic session with the BFR on their legs and have them just turn it over and get that benefit of the aerobic capacity without really pushing them too hard. Or we could get them in the gym and have them do some light activities and get that benefit of the recovery. And then the other thing I really like this for is our older athletes. We have a player who's 36 years old, and he's still playing at a very high level, still playing very, very, very well, but he just has a hard time lifting the same amount of weights that he used to. So getting him on the BFR, we did that last year, and this year he's been great with his strength work, but we did it the whole season last year where he would come in and do BFR exercises 2 days a week. And that really helped him to have one of his best seasons and look the best that he has in a really long time. And that benefit has kind of come over to this season. There's our references for any questions that you have. And that is all from me.
Fantastic, Nathan and Alex. A really good insight into how you're implementing BFR within your environment, and really interesting to see the journey that you've gone on to integrate it within both the, rehab setting, but also in your main program. From a couple of questions I had just in regards to the management of the use with your post-acute injuries, are you just using it predominantly in that rehab phase, or are you continuing some usage once they return to full training and are in competition phase again?
It's really dependent on the athletes. Some of them will continue to use it. Alex does a good job of once a guy has a hamstring injury, then the number one thing for hamstring injuries is if they had a previous injury. And so he blocks them into these groups where they'll continue to do some hamstring strengthening. And a lot of times they'll still come with me and I'll continue to do some hamstring work with them as well with the BFR. And so we kind of hit them from both ways, but it's really dependent on the athlete. Some of them continue to have just a small amount of deficit that we want to continue to work through. And sometimes they do well and we can push them through and they don't have to kind of stay back with the BFR, and we're able to push their exercise.
And you highlighted some of the exercises for the quad specific rehabilitation and ACL rehabilitation. With your exercise selection with BFR, are you limiting it to just 3 to 4 exercises rather than them using it on a larger spectrum? Do you try and keep it to more compound-based exercises or specific kind of isolated exercise if you are dealing with a hamstring, for example? So just using it when you're doing hamstring-specific work or quad-specific work. Do you bucket it like that?
Again, sometimes I'll do both. Sometimes if it's a quad injury, let's say, I might just focus on the quad and have them really focus with the BFR on the quad. But then occasionally I might throw a hamstring in there just because, you're going to disuse everything. And so I think, having that additional benefit of working different muscles, obviously you're going to get the benefit because it is systemic. And so even if I don't do any hamstring work, the hamstrings will still benefit from me just working the quad because it is systemic. But I do like to just add several different exercises. I'll typically do 3 or 4 BFR exercises, and I'll do that at the beginning of the session. And then after that, I might take the BFR off, and then we'll do some hamstring work or some glute work without the BFR on. But that BFR, the benefit of doing that BFR first will last for about an hour or two after we even take the unit off. And so we can continue to get some strength in that swollen and pooled state for about an hour and two. So everything we do after we do the BFR continues to have some benefit.
Yeah, excellent. And with you spoke about the girth measurements. Have you guys done any DEXA scans as well to possibly look at muscle volume comparisons post-surgery or immobilization?
Definitely. Unfortunately, right now it's a little bit hard because the DEXA scan is at another facility, and it's not a facility that goes through the rigorous testing that we go through. And so we haven't got any of our athletes in there yet just because we don't want to expose them to a place that potentially it could get something. And so we haven't done that yet. But yes, typically we would be sending our athletes frequently to get DEXA scans so that we can really see where is that growth, how much growth are we seeing over time. And so in a previous ACL that we had, we actually did send him 3 or 4 times during his rehab to look at that and make sure that he was headed in the direction we wanted him to get headed in. And he was actually getting the girth that we wanted to in the muscles that we wanted to, and it just wasn't some other tissue giving us girth.
Excellent. And Alex, from your perspective, with some of the performance assessments and testing that you're seeing possibly after some of those longer term athletes who have had exposure to BFR, are you seeing that they're returning to their baseline measures for either rate of force development or peak force development on any of the tests that you're doing?
With some of our preseason screening, obviously in football we do a lot of horizontal jumps and do some vertical jumps too for rate of force development. And we do see like minimal to no change as far as the screening process. Actually, we had one player, I'll be candid, we had one player that actually got stronger, beat a lot of his preseason scores on the force frame and things like that by applying BFR exercises for how long now? I want to say a couple months. He was going for it, but he actually knocked some of his scores out of the park and beat his preseason scores, which is fairly uncommon seeing as we're in this congested phase right now and we anticipate him being a lot lower. But yeah, generally across the board, I feel like it does shorten the period of loss of rate of force or even strength, just general strength.
And from an in-season strength perspective, where Nathan spoke about using it during the condensed period, are you trying to integrate that with your compound lifts in thought, or are you kind of using percentages of 1RM as Nathan spoke about to try and continue to get strength adaptation in those periods?
That's tricky. Like I'll even mention today we had a lift today and it was posterior chain dominant, but we had one player that's healthy in training and available for selection this weekend, but we only have 3 days to try and get him strength exposure. So he's actually off to the side, still within the team environment, but off to the side doing our anterior chain day, but using the BFR. So it's we only have so much equipment. So when we have like our squat day, squat pattern day, we only have so many racks that we can use. So we just flip-flop certain individuals and try and get those adaptations that way, if that answers your question.
And with that, is it similar concept, just trying to use the BFR on 1 or 2 primary exercises as you spoke about, and then complete the rest of the program on a modified volume or intensity?
Yeah. So that individual we had today did his leg press with a BFR, and then he came off and did the same supplementary work that was prescribed to the rest of the team on that anterior chain dominant day.
And you spoke about the pain mitigation component with possibly the tendinopathies or chondral defect athletes. Are you finding that with those tendinopathy athletes, you're using BFR for all of their tendon loading, even if they are symptomatic or asymptomatic, or are you kind of phasing it in and out dependent on symptoms?
So we'll phase it in and out. Typically, I'll use it on alternate days. So with a lot of the tendinopathies, it's a daily activity. So whether it be like an Achilles tendinopathy where you're doing the isometrics on daily, or a patellar tendinopathy where you're doing eccentric work daily to try to build up the tendon strength and its tolerance to activity. I'll alternate those days. So I'll do, his strength work every single day, the eccentric work every single day, or the isometric work every single day. And then alternating days, I'll do a couple extra BFR just to build a little bit of strength. The athlete that we have in particular right now has a noticeable difference in girth between his right and left quad. He's left dominant. And so his left is very, very pronounced and very large, and his right is just kind of there. And so trying to build some muscle mass as well in the muscle, while at the same time addressing the tendinopathy, which I think is going to be beneficial for him in the long run. And so I will do it alternate days. Sometimes eventually we'll be able to phase off of that, hopefully, and he'll be able to get back into the normal team lifts again. But yeah, for right now, we pull him off to the side during team lifts. We'll do a couple BFR things. He'll do a couple supplementary things, and then he'll be done. And then on those alternate days, we'll just do his normal strength stuff that I would do for the tendinopathy.
Yeah, excellent. I think definitely some of the benefits we've seen in an AFL setting for that pain mitigation from a tendon perspective and the chondral defects perspective shows great advantage to using the BFR. With those longer term chondral athletes or degenerative joint athletes you spoke about, Nathan, are you finding that hitting them more frequently, so 3 times a week, is more beneficial with the BFR than say a standard once a week that you may use?
Yeah, with those guys, 2 to 3 times a week is typically what we're going to use. So, they might be able to do some of the lifts with the team, but then we'll pull them to the side and have them do 2 or 3 times a week, on the side with me where they're focused on that BFR, whether it be, just a body weight squat or something on a leg press or, even a knee extension. Where we can build some quad with those activities, and those are super beneficial for those guys. And so I think 2 to 3 times a week is good for that, and then they can do their other stuff that they can tolerate with the rest of the team.
Yeah, Probably should have asked the question slightly earlier, just for people who may not be as aware of BFR and the arterial occlusion pressure component. How are you measuring that in your environment to determine the percentage that you spoke about with each of those strategies?
So the unit that we typically use in our facility that we have, it gets that number by itself. And so you put the sleeve on, you tighten it up, and then you just start it, and it will calibrate to each person. So every single day we use it, we're going to put it on and calibrate it to them, and it's going to give us that number. We can set how much occlusion we want, but it's going to give us the APO automatically. And then we just say, okay, I'm going to work at 80% of that, or I want to work at 50% of that. And so we can just dial that down, and it will give us that number, and then it will keep it steady at that number.
Yep. Yeah, excellent. Well, really enjoy the presentation today, guys, and the insight into what you're doing as a program at Houston Dynamo. The framework that you set out from a return to play model definitely is a fantastic model that could be put into any high performance environment. So it's a credit to yourselves in what you're developing there, or what you have developed there, and obviously how you're integrating BFR is really beneficial at the moment. So thanks for the presentation, really insightful, and all the best for what's next for you guys. I know that you're working hard, not necessarily knowing what your schedule is and when your games are coming, but with everything you've spoken about today, I have no doubt your players are well prepared for whatever's coming.
Yeah, thanks, Alan. Appreciate that.
Thank you very much.
No worries at all.